There we go. And of course, I make that available afterwards. I apologize that it sometimes takes me a few days or a week to get that recording processed and out to people. That's just life, but I appreciate your patience. And so, without further ado, why don't we just go ahead and kick things off? Carol, welcome.
Thank you, Allison, and I'm delighted to be here today with all of you. Thank you for having me. Um, I am a family physician and a geriatrician. I've spent a 25 plus year medical career. That was after the 10 years of training. I've spent a long medical career taking care of patients with complex issues, mostly older adults, many of them with dementia and cognitive impairment. Currently, I spend a good bit of my time teaching. I work in a residency program and geriatric medicine fellowship program, so I spend a lot of time training our next generations of physicians to be really good at caring for complex older adults. Um, and I also do a lot of work advising healthcare companies and how to improve their care of patients with dementia. So, and then Allison and I are on a couple of different boards and committees together because I'm also really interested in helping the systems of care that exist work better for, especially for people with cognitive impairment and their care partners. So it's a great honor and privilege to be here today. I personally believe that the caregivers of people with dementia are the real MVPs, the real superheroes. So really, really my honor to be in a room with you today. Coming to you from Seattle, where it's a beautiful, still morning for another hour, and I've spent my whole medical career here. Although I was born and raised in Louisiana and did all my education on the East Coast, so I've lived in a bunch of different places, but pretty settled here now. I'm going to share a few slides and just go through a little bit of a presentation. That's going to take me 10 to 12 minutes. And then we'll have plenty of time for questions. Don't hesitate to put things in the chat or interrupt during the presentation if you need to. But like I said, we'll have lots of time for discussion after. And I love answering questions. So don't hesitate to keep track of what you want to talk about. Before I launch, I did just want to start by asking you to put into the chat, what's the most stressful thing about going to a doctor visit with your loved one with dementia? What's the most stressful part? Maybe just put some answers in the chat so we can sort of see where people are at with this topic. Yeah, so right away I'm seeing a couple of really common ones. Not having enough time. Your mom takes the patient longer to answer questions, not being able to ask hard questions with the patient present for sure. Patient's understanding on the part of the doctor and the patient. None. He's a good friend. That's great to hear. There's certainly many wonderful people doing this work out there. Loved one doesn't answer accurately. Yeah, that's really challenging, right? You know what the truth is, and that's not what's being conveyed. Provider not familiar with cognitive impairment. Yeah, I'm spending my career working on that problem, but it's a big problem. And then someone else who's very grateful. So super, thanks. You can keep putting them in there. I'm going to go ahead and move on to sharing slides now. All right, screen sharing. All right. So, yeah, we're just going to talk a little bit about the just general topic of a visit to a doctor and how to try to make that difficult situation a little bit less stressful and a little bit more effective. And again, I'll just echo that I'm delighted to hear many of you are having excellent experiences with that already. That's great. Okay. Okay, now I've succeeded in putting your pictures right on top of my slides. Okay, there we go. tech. All right, so I'm just going to start with a few observations based on a long career of doing this work, just to sort of level set for the reality that we live in today. We work in a system, all of us are subject to a healthcare system that does not reward thoughtful, person-centered care. You know, the things that we've decided to pay a lot for and the things that we've decided to pay a little for are different. And the things that we've decided to not pay a lot for includes a lot of talking, thinking, working with complicated people and complicated problems. So the visits are too short. And then a lot of times the work that's done outside of the visits, you know, follow-up phone calls or messages on the electronic portal or whatever, is generally uncompensated care and therefore not encouraged in health systems. So our system doesn't reward the kind of care that patients with dementia and their loved ones need. Secondly, multi-complexity is the norm in patients with dementia. So what do I mean when I use the word multi-complexity? I just mean that patients with dementia commonly have a number of medical conditions that are all intersecting and relating with each other. Medicare data suggests that most patients with dementia diagnosis have 5 or more other chronic medical conditions. Things like heart failure, COPD, high blood pressure, high cholesterol, heart disease, and especially in a primary care setting. So I work mostly in primary care settings. The physician is often trying to manage all 5 of those other things while also managing the dementia. And that's the norm, not the exception. And that's actually quite complicated, hard work. Third, many physicians and other clinicians lack training and experience in dementia. That is also a reality and something that I spend a lot of my current energy trying to solve, but it is not a problem easily solved. This plays out in a couple of different ways. First of all, underdiagnosis and delay in diagnosis is the norm. In the US, it's estimated that from the onset of the first cognitive symptoms to a diagnosis on average is 2 years. So it takes a long time. And so that to me is sort of a symptom of the fact that we're not very good at making diagnosis in our systems. Another place where this sort of lack of experience shows up is sometimes physicians aren't as good as we would wish at considering the patient's dementia context when they're managing their other medical conditions. So, for example, a really complicated insulin regimen for diabetes that might be totally inappropriate in somebody with dementia who can't dose their own insulin anymore. But they don't always think of the context of the dementia when they're making decisions about the other medical problems. Thirdly, the skill of communicating with both a patient and respecting that person's autonomy and a care partner who knows a lot about what's really going on is a skill that many clinicians have never developed, and it's not an easy thing to do. And that's just another place where sometimes lack of experience can show up. So often either the patient feels shut down and angry, or the care partner is unable to say the things that they need to say in the visit, and that's a real problem. I'll also just observe that a lot, especially kind of in the early stages of a diagnosis, a lot of what dementia family caregivers need is education about the disease and support. And those are critical unmet needs in many, many places. So I am delighted that Allison and her team do the work that they do to try to help build support and structure for people who are going through this, because those are critical unmet needs that are not well met in the medical system. The medical system is sort of not the best place to get those things done. And then lastly, just an observation that we're all humans doing our best. That goes for the doctors, it goes for the people living with dementia, and it goes for their care partners. So I think sometimes in a frustrating system, just recognizing our common humanity is kind of the best we can all do. So I'm going to talk a little bit about kind of how to think about before the visit, during the visit, and then after the visit. So maybe 3 or 4 more slides and then we'll be done. So before the visit, I think it's good to have a realistic expectation about the time. You may be able to learn that when you schedule the visit. How long do we have for this visit? So is it 20 minutes? Is it 30 minutes? Is it 15 minutes? It doesn't mean, you know this well, it doesn't necessarily mean you're going to get that much time, but at least you have a framework for if you know what you have is a 15-minute visit, and you know that of that, probably 8 or 9 minutes are going to be with the doctor, you sort of can know what to expect. So, realistic expectations about time. Secondly, I just think it's good to sort of prep before you go. So, what are the top 2 or 3 concerns that you have, and write them down so that when somebody says, "What are you here for today?" you don't have to remember, you already have it. Always really helpful to bring your medications, the list of the meds or the bottles, and to highlight when you do that any if there have been any changes to the med list since you were last in, or if there are any real barriers to taking the medicines, side effects, or they refuse to take their pills, or we can never remember to do the pills at night, or whatever it is, just recognizing that stuff. Thirdly, sort of keeping track at home, and then bringing in any recent changes with behaviors or changes with cognition. And it's really useful to bring specific examples and to sort of, like, he left the stove on last week 2 times, something that's sort of really concrete and concise. Similar safety concerns. And then if there's any that's relevant to the care, just trying to remember to bring it. If maybe you completed an advance directive and you have a copy of that you want to put in the medical record. Maybe your loved one lives in an assisted living facility and they have some forms that they need to have filled out. Like, bringing those things in, and even just giving them to the medical assistant when you first get roomed, can just sort of get another piece of work done, and not have to sort of spend some of your precious doctor minutes on that stuff. Third thing that I think about preparation: if you know that you're not able to speak openly in front of your loved one, try to let the office know ahead of time. Now, I will say that different offices have different levels of ability to deal with this. But I promise you, they have to deal with it sometimes. And it's better to give a warning shot ahead of time so they can think about how they want to address that. And then you don't have that stress of, like, you're walking to the exam room and you're trying to pull somebody aside and say, "I need to talk about it." Or worse yet, the visit's already over and then you're trying to pull someone aside and tell them, just say, like, find out how they would like to handle this problem. Let them help solve the problem of, I need a chance to tell my concerns apart from my loved one. What's the best way to do that? I'm including here just a couple of tools that we use in our dementia clinic that may not be widely used, but they are free and in the public domain, and you can find them on Google. If you are someone who sort of likes a systematic structure to capture how is my loved one doing, these are tools that we use to do that. One is the Dementia Severity Rating Scale, which is sort of a list of cognitive concerns and sort of how someone is doing on those cognitive concerns. And then the NPIQ, or the Neuropsych Inventory, is a list of common dementia behaviors that may be problematic. So I just offer these as a potential suggestion. If you're somebody who's like, I don't know, I can't think of what behaviors or problems, maybe just print these forms out and fill them out and bring them in, if that will help you sort of be organized. The advantage to those too is that they can be used to track changes over time. Okay, so during the visit, we already talked about, we know the time is limited. So the thing that I think is really the most important is to make sure that if you have real concerns, to present them up front. So sometimes people are uncomfortable or they don't want to be a bother and they end up not or the doctor comes in guns blazing with, a bunch of things they want to talk about, and then the things that you actually want to talk about get squished to the last 30 seconds of the visit, and that's terrible. I think it's actually quite important to bring your concerns up front. If there's a medical assistant rooming who says something along the lines of, tell me why you're here today, that's your chance to say the things that you really want to talk about. You can practice ahead of time being concise and direct about those things. I recommend, and I teach my physicians that I work with, I teach them how to negotiate an agenda for a visit with a patient. And so I say to you also, you get to negotiate an agenda with a physician. So what is going to happen in a visit? You often have things that you want to talk about, and the physician often has things that they want to talk about, like maybe there's a lab value they need to tell you, or maybe there's a change to your medicines that they want to make. And really, like, both are valid. And I think it's a really useful use of time to take the first 2 minutes or 3 minutes of the visit to talk about, like, what are we actually doing today, and get everybody in agreement about it. So that's what I recommend. Negotiate the agenda up front. Again, if you haven't done so ahead of time, I think it's okay to ask about the best way to share your private concerns. I have some things that I'd like to share privately. What's the best way to do that if you don't know? The other guidance I would just have is that if the current plan of care isn't working for some reason, either it's too complicated, it's too expensive, it's not realistic, it's okay. You should let them know. You should let them know rather than assume, rather than feeling like you have to be ashamed of it. It's very, very common for people not to do the perfect textbook care plan that was written in the chart, but it's much, much better to share, this isn't working. We need a new way to address this problem. I recommend that people take notes at the visit, but I will acknowledge if you're there as a care partner with a person living with dementia, you're also trying to navigate that dynamic, and it's often hard to take notes while you're doing all of those things. So maybe think about bringing along a note taker. Is there a friend or a relative who can come along to just sort of be a little bit more of a neutral observer and see what happens? That person, maybe if the office is agreeable to it, can even be on the phone or via telehealth. My mother, who's in her 80s, lives in Texas, and I attend her visits through the video. And I'm just quiet, but I can write down all the stuff that happened in the visit so that I can make sure we all are in agreement afterwards. And then lastly, just back to the common humanity thing. If you have genuine gratitude for the care that you're getting, it's okay to express it. I will tell you, today's doctors feel sad and underappreciated and overworked. And that's not to say that they're any more deserving of recognition than anyone else who works hard. Certainly not, but gratitude goes a long way. So if you feel gratitude, you don't have to bake cookies, you don't have to send flowers, you can just say thank you. It goes a long way. So after the visit, the goal is that you make sure you understand what happened and what the plan. So you should get some sort of a written summary. That's usually standard now. And after visit summary, maybe you get it handed to you in the visit. Maybe it comes to you afterwards through the electronic portal. But really to understand, like, what happened in the visit and what's our plan. And then make sure you know, and if you don't know, ask, what's the best way to communicate if we have questions or problems between visits? So there's not a one size fits all answer here, which is why it's good to understand for this office, like, what's the best way? Is it electronic portal? Is it a phone call? How should we do that? Similarly, along those lines, like, is there somebody else who's not the doctor who can help, right? Some practices have a nurse who's really super amazing and helpful. Some practices have a social worker, same thing, right? So is there somebody else who can help us with problems in between visits? And then thirdly, really sort of back to the problem of, Non-visit care by physicians is fundamentally like uncompensated care that docs are doing kind of after hours in their pajamas. And they do that every day, all the time. But complicated problems are not going to be solved without a visit. So if you're having trouble getting the attention of the office for a problem, make an appointment. It could be telehealth appointment, whatever. But if you make an appointment, you are sort of giving the doctor 15 minutes at minimum to think about your problem. And if you don't do it with an appointment, then you are hoping that they have the time and energy to think about your problem at 6:30 at night when they're done writing their notes for the patients they saw that day. And you just are not going to get their best game, honestly. So, complex problem, make a visit. And then know the plan for follow up. So, I usually recommend to do fairly frequent visits, even though I totally recognize that getting a loved one with dementia to a visit is a big stress all of its own. And that's why I also recommend to understand what telehealth options are available. So I care for many patients with dementia over the years using telehealth with only maybe the occasional visit in office to check on some physical exam stuff. But we can do a lot through a video visit, patients in the comfort of their own home. Loved one has a little more freedom to say what's going on. So think about and ask about telehealth options if those are available. Okay, I'm going to stop talking now, but I do just want to end again with thanking all of you for what you do. Super, super important and wonderful work, and it's great to be here today. All right, Allison, you tell me what is the best way to go forward?
Sure. Well, I didn't mean to raise my hand. I just meant to send a heart, but that's okay. Well, you addressed a lot of the things that were popping up in the chat, um, especially about how to, like Chuck had asked, how to get more detailed, give more detailed information without upsetting my wife, or how do I have conversations that are difficult for my loved one to hear me have. And I know that um, I asked, I followed your instructions, even though I hadn't even met you yet. And that is that I had a conversation separately with my husband's doctor. And there was all this, I mean, the HIPAA stuff, I get it, right? It's there to protect the person. But at the same time, um, talk to me. I'm the voice. I'm the one who's able to actually communicate. And I understand that there can also be bias, right? The caregiver who is completely flipping out because they're so frustrated is not necessarily always going to be a reliable narrator. And I have to believe that that's something that causes issues for the doctor sometimes. But it really helped me to have a conversation with my doctor and figure out what was the best mechanism for conversation. And for us, it was that I created the patient portal account for my husband. And then I just logged into his account and I asked questions, and she graciously responded to those questions. And she knew that it would be very difficult for us to have a conversation with him in the office. He would get angry. And so we started, excuse me, I would bring things that were interesting for him to use. If I had had it then, right? Zinnia TV running on a laptop or on a tablet, I could have him sit outside and give him something to keep him busy while I had a few minutes by myself in the doctor's office. And the team, her team, all knew that that was okay with us, that it was okay for him to sit in the lobby. But if he started getting agitated and looking for me, that he would be brought in. Anyway, I really appreciated the clarity around what you said about the fact that it's not just hard for the patients and the caregivers, it's also hard for the physicians as well, and that we all need to be pretty open-hearted, I guess, about what's going on. And there are doctors who are better and less skilled at being able to support people. But anyway, I would like to open up to the folks who are on the call to just ask if it can be questions about the doctor's visit, but it can also just be questions about stuff that's going on. We're a support group. So what's the stuff that's going on for you that you would like to have the group chew on and help solve. And then we also happen to have a geriatrician in the room who might also be able to help with some of those issues. So feel free to pop things into the chat, or if there's just anything that's going on with you right now that you want some help with, this is the forum to do that. Yeah, Chuck.
I'll raise a follow on. In several conversations with the doctor, and we're talking to a neurologist, the issue of there's some background things that are popping up in my wife, who's kind of in a mid stage of things that happened years ago that are irritants. And so the question has often been made is there a value going to a psychologist or some therapist to allow them to have that kind of treatment? So my guess, my question is, what do you look for other doctors that may be providing some support or service than general practitioner or whoever you're working with?
Yeah, it's a good question, sort of how to make sure you build the right team to take care of you, right? And I would say, and the answer varies depending on the stage of illness, right? And also kind of what's available locally. So there's a bunch of different variables. Um, I'm lucky enough in my practice, we have integrated behavioral health. So we do have some clinical psychologists and social workers in the office that can kind of be part of the care. And Chuck, I'll tell you what I've learned from the behavioral health team over time is that they say that if a person is advanced in their at all in their cognitive impairment such that they really lack insight into their deficits and into where they are, they don't benefit from typical therapeutic interventions of the type. They don't really benefit from seeing a psychologist and working through stuff from their past because they don't sort of have the insight to then process that. So there are some types of therapy that are probably more appropriate for patients with cognitive impairment, sort of reminiscence therapy. And there's some other particular skills, but I wouldn't say that a sort of a normal therapist knows that, or that and they might really be better done by social workers, or they don't necessarily need that level of therapeutic expertise. They can be sometimes done by speech therapy, occupational therapy, other professions like that. So it's not harmful to do to explore the past. I think, but thinking that that therapy is gonna help that in the way that it might for a cognitively intact person is less true.
Thank you.
Yeah.
I want to pop in there for just 1 second and lean into the idea that it's so nice to be heard. And so I think that oftentimes for our loved ones, to have somebody who is focused on them and who's just listening to them and who's not going to get frustrated with them. And so, to Carol's point, I think it needs to be somebody who really gets what dementia is. And there are therapists, and I can make recommendations. If you'd like, Chuck, I can follow up with you. Or I can put it in my follow-on email. There's a person who I work with who specializes in therapy for people who are living with dementia. And to Carol's point, it's not about necessarily coming up with resolution, as you might be, Chuck, if you were visiting a therapist, but it's more about allowing a person to feel deeply listened to.
Thank you.
Hey, Tamara, do you want to pop off mute and ask your question?
Sure. I just wanted to understand what sundowning is. I've heard the term, but I don't really understand what it means. And I know with the time change and it getting darker, my dad just gets really confused. And then he has a lot of energy at night. And he's been reorganizing and reorganizing the garage so where we can't find things. So we've been giving him melatonin for him to sleep, and that's helped. But I just want to understand what changes are going, like what is sundowning and what changes are happening to him.
Yeah, thanks, Tamara. That's a common and challenging problem, and I'll I'll maybe do the definition, and I would love to have others weigh in on, solutions that they have found helpful. So all we mean, so we know that the symptoms of people living with dementia are not steady, right? They wax and they wane. And sometimes they wax and wane across days, and sometimes they wax and wane across hours. And we don't exactly understand why that is, but neurocognitively in the brain, you have these problems that are happening inside the brain, and then also your ability to cope with what's happening inside your brain waxes and wanes. And so, what we commonly see in patients living with dementia is that as the day goes on and as it gets close to sundown, they just sort of lose a level of organizational ability to keep it together. So, not unlike, toddlers do that too. Sometimes there's this sort of, I had a family friend who called it the gangrene hour, like when all the kids came home from daycare and everybody's freaking out and running in circles. And, so I just think in a way, similarly, there's just this sort of lack of organizational ability that wanes through the course of the day. So it doesn't really mean something is wrong. It's really, I would say, sort of just part of the natural course of the sort of day-to-day reality of cognitive impairment, which is that it's not constant over time. So, but I would love to hear maybe if others have thoughts for Tamara. I'm sure other people have dealt with this.
I'll have an opinion. I think that if we start noticing, Tamara, that there is like, oh my gosh, like every day in the afternoon, it's almost like clockwork. And then for a couple of days, it isn't. And then it is. But that there's this time of day when he starts just kind of getting unraveled. A couple of things to remember. One is that it is exhausting to have dementia, exhausting. So there was a woman who I heard lecture who is living with dementia herself. And what she talked about was she said, even getting up in the morning, and I apologize to people who've already heard me say this, but even getting up in the morning, you with your healthy brain, you sit up in bed, oh, you stretch, you kick your feet over the edge of the bed, you get up, you go to the bathroom, you go downstairs, like the whole day is ahead of you. And you're not thinking, you're just on autopilot. And she said, for me, now that I have dementia, when I wake up in the morning, it's an effort to, okay, I need to sit up. Okay, now I need to, okay, put my feet over the edge. I need to stand up. Wait, my feet are cold. What are the, oh, right, slippers. And she said, so by the time the midday to mid-afternoon rolls around, I am wiped out. My nerves are on edge. I'm fritzed. So it's not unusual then that when that starts to really kick in towards that end part of the day, that people might get a little frustrated. Also, think about the fact that that time of day is a time when a lot of people would, when they were healthy, have been engaging in an activity. This might be when it was time to go pick up the kids from school. It was time to start dinner. It was time to start wrapping up my work so that I could leave the office. And so there's this part of the personhood that still recognizes that, oh, the sun is starting to set. I'm supposed to be doing something, but what is it? What is it? What am I supposed to be doing right now? And so that can add to frustration. So one of the things that we can do is recognize that the time that typically starts to happen and engage the person in something that is meaningful and that they like to do prior to that time. So
Right.
that might be the time that we sit down and we say, hey, tea time, and we have a cup of tea and a cookie. Or maybe it's the time that we put on some sort of nature programming that they find relaxing. Or if there's something that they really like that they're good at, that they like to do with their hands, that's the time that we engage in that. Or maybe it's just the time that we get them to breathe with us a few times. Let's just hold hands. You got this? And let's take a few deep breaths together to lower their cortisol before it starts raising up because of the anxiety that they're feeling. So just a few thoughts about that.
Thank you. That's helpful.
And Tamara, I'll say too, this at what she just said, and a lot of my other support groups is the first thought is, or the first piece of advice is get ahead of the situation. You know, when you know if it's 4 or if it's 5, and do something like what Allison just said. The other thing too is he sleeping a lot during the day, or is he active during the day?
No, no, he's active during the day,
Oh,
and
good.
when we're ready to go to bed, then he has all this energy, and we're like, go to bed because we're all going to bed.
Yeah, right. I know. And Stephen, you pointed out in the chat that it helps you to for Debbie to have naps a little earlier in the day. So, yeah. Thank you for that. And let's talk to Anne. Anne, do you want to unmute and ask your question?
Um, yeah, my question is about how, my mom continues to repeat things, and that she's at a stage where that's everything. But the medical issues are the ones that I have a hard time really knowing, should I do something about it, or is it kind of a repetitive thing that she's saying? And things like tummy cramps she's had for years because of colon issues, and they're not severe, but certainly they could be. That's one example. Others could be like a muscle ache. That's not a big deal. And I used to call the doctor all the time about it, but I do that a little less now. But I'm at that stage of wondering how much I should be concerned about things, not knowing if they're really mild or if they're more severe.
Yeah, that's a real tough one. And thank you for bringing that forward. Because fundamentally, right, it's kind of a judgment call. So I often, when I see patients who are saying the same complaints that I know we've addressed before, I kind of have a standard like, I'm so sorry that you're going through that. And then I just stop and I touch them and I move on. Like I don't try to go like into a like cognitive place with it because it's not helpful. I don't try to repeat, well, no, I've done this and I've done this and I've done, we've done like that doesn't help. I just try to say like, I'm sorry that you're experiencing this thing.
Yeah,
And then move on, which is
yeah.
you could say that's dismissive, and we do run the risk, I suppose, of missing. I mean, we're always running a risk, right? We're trying to balance that out, but I think it is fair to assume that if it's really something different and new, there's going to be other signs, right? It's not just going to be a pattern. And by recognizing a pattern and identifying that to your doctor, you're doing them a huge favor. You may need to take your mom because like sometimes that's the easiest thing to do, right? But if you come to the visit and you present and you say, she's talking about stomach cramps, and I will say that she has talked about this consistently for 25 years, and we've done a number of workup and haven't found anything, like just to like set the stage for them, like that doctor's like, oh my god, it's like a huge relief to just know some of that background.
Yeah.
So you're actually super valuable to her because of that perspective that you have.
And because verbalizing the symptoms any deeper, like that's not going to happen.
Right. It doesn't, frankly, it doesn't help. So, I think, sometimes I'll use my physical exam a little more liberally, like, okay, well, I really want to like take a look at your tummy. So sit on the exam table. I'm going to like, mash around and get out my stethoscope, just use some of my like doctor tools to try to sort of, I'm also looking for something that makes me more worried, right? So it's not just theater, but it is a little bit theater. It's helping them feel heard and understood. But what I try not to do, and what I hope physicians don't do, is just, oh, I don't know, I'm going to get some tests, right? And because then you just end up in this cycle of like another urinalysis and another blood draw and another CAT scan, and that just doesn't help anyone, honestly. So I try to avoid that cycle when I can.
Thank you.
And I might add, just like with the little tummy cramps, just ask her, well, oh, did you eat something that might have caused that? Or
Oh yeah, she doesn't know what she eats.
well, but at least you're asking though, like
Right,
you're
yeah,
concerned. You're
Yeah.
not saying, oh, you've had them for
But
25 years.
that frustrates her because she can't remember. So
Oh, I
I
gotcha.
don't
Okay.
ask that anymore.
Yeah.
Or maybe that's true. Yeah.
Yeah.
Or
But
say,
I
oh,
do
well,
offer, would you like a Tums? And usually the answer is no. And if the answer is
right.
yes, then that's harmless, right? Like she can
Yeah.
take it. Yeah.
I don't know if this would be comforting at all. It's comforting for me. And that is that I have this little stuffed animal that is meant to go in the microwave, right? And it warms up, and I sit with that on my tummy. And there's this sort of like, ooh, I know it's not a kitty cat, right? And for many people who are living with dementia, like, I know it's not a cat, but it sort of brings back memories of a cat. And so that's something that can be sort of both cognitively soothing as well as physically soothing. Just a thought.
I like that very much. Thank you.
Yeah.
Great advice.
Janine, was there something you wanted to? I know you popped something into the chat. Do you want to offer that
Sure.
up?
Yeah, I was just curious because we have, had an evolution of care providers, and I think I mentioned my husband has had early onset Alzheimer's for 9 years. Well, we're not, that's when it began. We're not in that stage any longer, but also diagnosed with Parkinson's recently. So as a result, we have two neurologists, and I have an upcoming just the annual Medicare visit with the primary care, who happens to actually be her specialty is pediatrics because that was how we got into the UW's neurology system by having a UW primary care, and that was the only one we could get. So I'm wondering if we should be looking for someone with geriatric specialties, or because we have two neurologists, are we, how much of a switch should we make, that kind of thing. So,
Yeah, I think this is a tough one for a number of reasons. First of all, you finding a geriatrician who is available to take on new primary care uh, patients is a big mountain to climb. Is your UW University of Washington or is it Wisconsin?
we're in the University of Washington, so that's where
Yeah.
neurology.
Okay.
We've got a Evergreen and a UW
Yeah.
neurologist. Yeah.
Okay, I know. I've been fooled by the University of Wisconsin folks. That's why I asked. Yeah, the so just little local knowledge. There is a senior care clinic at Harborview. We also have our clinic at Swedish Family Medicine at First Hill, that are both places that you can actually get a practicing geriatrician. Both of those are training settings, which means you have to deal with the chaos of like fellows and turnover and some of the chaos of a training clinic, which doesn't work for everyone. But I will tell you, the care is excellent because you get a lot of thoughtfulness around the whole picture. I would say, what geriatricians are, so neurologists, and again, like said with love, like I love and admire my neurology colleagues. What they are really, really good at is brain pathology. Right? They're really, really good at like what's happening in the brain and what are we going to do about it and what are the latest tests and treatments, right? Geriatricians tend to be good at like, this is a person who is aging. And so we need to think about all these factors running together. We need to think about their mobility. We need to think about their mood. We need to think about their thinking, their dementia. We need to think about multi-complexity, all their other medical stuff. We need to think about their meds. Are they on some medicine for their blood pressure that's making their cognition worse, right? Like geriatricians are really trained to think like that, to think more broadly, and fundamentally to start in geriatrics, when we're doing our best work, we start with the question of like, what matters most? So what are we working on to try to get a person functioning at the level that is, highest possible, and like what matters to this patient and family system. So those are the skills that good geriatrics can bring to care. So as to what in your individual circumstance, I don't know, there are plenty of excellent primary care doctors. If you find that you're feeling heard and listened to and they address your concerns and they are thinking about what matters, then you may be in the right place. And if some of those other things sound better, come see us or try some other places.
Thank you. Yeah.
Yeah.
And I was also just going to share too, based on one of the other comments that I think it was, not knowing like the stomach aches. My husband had some changes in behavior. He started sitting sideways at the table, and I just chalked it up to changes with Alzheimer's. Turned out he had a detached retina. So sometimes it's so easy to miss things because, how would I have known? He was, you know, so it's hard to know when to double check on things. We happened to have an eye doctor appointment and found out. And he said, "So how long have you not been able to see out of that left eye?" And I'm like, "I didn't know."
Yeah.
Could I miss
Yeah.
something
And
that
just
big?
again, like, yeah,
Yeah,
we're all humans doing the best we can,
exactly.
right? No one's fault. It's just one of the challenges of the illness for
Yeah,
sure,
it's
is the
hard.
inability to accurately report symptoms. Yeah, for sure.
Arnie, what were you going to share?
Yeah, I want to talk about something you mentioned there. I was going to ask this question anyway, but you brought it up, Carol, which is the meds. One of the challenges that you have is that over the years, you've got different specialists treating different things, and one med gets added, and then another med gets added, and so forth. With my wife, went through a period where she was having some challenges, and she ended up spending a couple of days in the hospital, really, really confused. And fortunately, even though he was relatively young, this doctor had spent 20 years working with senior care. And we had some great conversation. And he took her off a couple of meds that she'd been on for years. And but the challenge that I see is because it's often hard to find a geriatrician. Okay. Can you speak to the importance of finding a medicine gatekeeper, and who's the best person, or how do you raise that in a medical community that everybody's kind of looking at their own little niche and they're not
Yeah.
putting it? Because I will tell you that once he took her off a couple of meds he took her off of, she was better than before.
Yeah. Yeah. Well, thank you for sharing that story. Yeah, sad and common. Yeah, interestingly, so one of the things we run in our clinic is we have a geriatric assessment clinic where we do one-time assessments of people who come from all over the community. And we use a multidisciplinary team for that assessment. And one of the most valuable people on that team is we have a pharmacist. And she actually sits in the room and goes through all the meds and thinks about them all. And it's great. And I recognize that's not a normal situation, but it's just a reminder that these things pop up all the time. So my feeling is a good primary care doctor or clinician should be the quarterback and manage all of your medicines. They don't have to be a geriatrician to do that. All primary care should, they're worth their salt, recognize that it's their job not just to think about the liver or the kidney or the heart, but to think about the whole person and how is this list of medicines working. So just a couple of tools to like help sort of surface some of that. There's our pharmacist actually uses a tool that looks at anticholinergic burden. Anticholinergic is that means the kind of meds that affect the brain. So some meds, like for example, there are a bunch of meds we use for bladder problems that affect the brain. They have a high anticholinergic burden. There are antidepressants that have a high anticholinergic burden. And when you get a bunch of those, they start affecting the brain. So there's, I'll share it with Allison and let her share it with you. There's actually a website that you can use to calculate, just throw all their meds in a list and calculate the anticholinergic burden, which might identify like, looks like we might have a problem here, doctor. What do you think? Can we work on this? The other thing, I think it's always okay. What I hope for all patients and families is that they understand what every medicine on the list is for. And if you don't really understand what it's for and whether you still need it, it's perfectly acceptable to ask, why are we on this one? What is this for? Because a medicine list is not static. And it shouldn't be static. So sometimes what happens is there's like leftover stuff that's on the med list from 10 years ago that was perfectly appropriate 10 years ago. Is not appropriate today. So I think your best bet is your primary care doc. And I think it's okay to set a visit that says, I want to just talk about all the medicines today. That's the purpose of this visit. What are all of these for? Do we need them all? Is there any way we could peel any of them off safely? And let them take that on.
One of the things that he said was that these meds were fine when she was younger,
Yeah.
but they affect you differently as you age, and especially when you already have dementia, have Alzheimer's. And I think that was just an awareness that, yeah, I was like, okay, this needs to be an ongoing process as new things get prescribed.
Yeah, there's a list with a great name. It's called the beers list, like beers, like at the bar, but actually it was named for Dr. Mark Beers, who was a geriatrician at UCLA. And it's a list that gets updated periodically of like medicines that are bad for old people. You know, it's just like a shorthand of if you're on any of these meds, it doesn't mean it's totally wrong, right? It doesn't mean there couldn't be reasons. But these are medicines that should be used with caution and a really good reason, not just because somebody started it 10 years ago and nobody ever stopped.
I'm going to move us on because we're almost out of time, and there are a couple of questions I want to make sure that we get to. Paula asked the question about not being able to ask hard questions with him there. And Carol, I think you addressed that by talking about creating a way to connect with your doctor kind of offline, letting the office know that you're going to need a few minutes alone with the doctor, perhaps giving the doctor a note. I know families who will go in with a letter that they give to the doctor, and then when they leave, the doctor can respond to them afterwards. Is there anything that you'd like to ask? Or Paula, is there anything a way that you'd like to expand on that question in a way that I am not addressing?
No, I thought you did a beautiful job. Thank you.
Okay, cool. I'm so sorry that Janet uh, Rice left. I'm going to reach out to her afterwards via email because her comment was basically about it's too much. And I'm so glad that she was here today, but we'll make sure that we ring a bell for her or something another time. And then, Steve, there's a lot right now going on, isn't there, about the lithium? And you said research on lithium for dementia is proving very positive. I bought some. What do you think? Carol?
Yes, I would say that has not yet risen to the level where I feel confident about it. I'm very willing to acknowledge that there are things that may prove over time to be effective, but I'm very, very cautious with um, sort of anything new for the fragile brain. And so I would proceed with caution until we have more research.
Thank you. And I want to just go back for a second to the pharmacy question about the anticholinergics. So I was hanging out just a couple of days ago with a friend of mine who said, yeah, there's like 2 or 3 times a week when I need to get up at 5. So I always just take NyQuil the night before. And I said, bad for the brain. So NyQuil, Unisom, Benadryl, some of the over-the-counter things that we will take because I just need to get some sleep are not good for the brain because they have this high anticholinergic issue. So I just recommend that we not just think about the medications that our loved ones are taking. Let's also think about the medications that we're taking and whether there's anything that we're consuming that is actually going to be problematic later on for our brains. We don't want that. All right. We are at the end of our time today. Carol, oh man, I'm so grateful to you. Thank you for being here. And thank you to all of you for coming up with great questions, for being willing to share, right? For allowing yourself to be vulnerable and share about what's not working for you, and also for being here to support each other. So, and Carol says, biggest bad guys are benzodiazepines. Is that what we're okay? Sleepers and Benadryl. I know Benadryl, right? I think about when I used to sometimes give Benadryl to my kids, and I think, what have I done? Let go of the guilt. All right. Thank you, everybody, for being here, and we'll see you again soon. Bye bye.